Hi, I'm Elise Desperito. Thank you for inviting me to speak here today. It's an honor. I'll be speaking about imaging for all women, but particularly high-risk women. So the first few slides are things that probably most people in this room know. The risk of breast cancer increases as you get older. If you began to menstruate early, before age 12, you are at increased risk for breast cancer. If you go through menopause late, after age 55, you are at increased risk for breast cancer. Your risk of breast cancer is higher if your mother, sister, or daughter had breast cancer. This is especially true if your family member had breast cancer at a young age. Approximately 5 to 10% of American women who get breast cancer each year have a hereditary form of the disease. Now, you're probably all sitting there thinking, okay, well, great, thank you, Dr. D, for telling us that, because we can't change any of those things. So what exactly can we change? That's why we're here, and that's what we want to figure out. So a few things that we can change, and some of the other speakers are going to talk about these more at length. These are the ones that are just review of what we just went through. When you have your first child, you have some influence over that for sure. If you're going to take hormone replacement therapy, you can choose to do that or not to do that. And you can choose how, if you're going to be overweight, you can go on a diet and you can exercise. So we do have some choice in all of this. But the problem is no one knows the exact cause of breast cancer. Doctors can seldom explain why one woman develops it and another does not. And most women who develop breast cancer do not have a history of breast cancer in their family. So what can you change? You can change in the majority of cases when your radiologist, find your breast cancer, and you can choose to get a yearly mammogram. So what is my risk? I'm not sure any of you have looked at a mammogram before, but this is a classic appearance of an invasive breast cancer on a mammogram. And no radiologist likes to look up and see this on their view box. Nobody does. We all sigh when we see this and think, oh my God, if this woman had come last year, maybe this wouldn't be here. So, does a mammogram really make a difference? One of the leading radiologists in breast imaging, Daniel Copans, has shown in his research that if a group of 100 women with breast cancer are screened with mammography and clinical breast exam, 80 of the cancers will be detected with the mammogram. So mammography will detect 85%, and clinical breast exam will detect about 15%. Another 20 cancers will become palpable during the next year and will be diagnosed as interval cancers, which tend to be aggressive. And ancillary screening modalities, meaning ultrasound and MRI, can detect at least some of these interval cancers early. Now, the point being, if we all had a bomb in our kitchen, wouldn't we choose to remove that bomb? And so I'm going to talk about that in a little bit. We have a choice. We can decide to get a mammogram, and we can decide to act on what we see on that mammogram. Dr. Copans has stated that the only definitive proof of a benefit of breast cancer screening comes from randomized controlled trials with death as the endpoint. Well, what does that mean? A randomized controlled trial is an experiment in which people are allocated at random, so that's by chance, to a clinical intervention. In this case, the clinical intervention is a bilateral mammogram. So one group of women has a yearly mammogram while the other group does not. And the randomized controlled trial is one of the simplest and most powerful tools in clinical research. And the significant decrease in breast cancer mortality, nearly 30% since 1990, is due to, in large measure, the earlier detection of breast cancer through mammographic screening, and has been proven by randomized controlled studies. So, nothing to slight here. We have reduced death due to breast cancer by 30% since 1990. That's very significant. So let's talk a little bit first about anatomy. I think it's all important for us to understand our bodies, and oftentimes we don't particularly understand that, and I think that's important. We're going to talk about breast density. We're going to talk about how we define high risk and how you can define that for yourself. And we're going to talk about adjunct screening tools. So first, anatomy. The breast is composed of 15 to 20 lobes in most women during their reproductive years, and each lobe consists of numerous lobules and small branch ducts that join to form large ducts progressively until there is only one main subareolar duct. And you can see here with the mouth, mouse. Here are the small ductal systems, and here's the nipple here, okay? So the lobar ducts drain to the nipple in a general radial fashion that is similar to the arrangement of the spokes of a wheel. Most breast pathology arrives within what we call the terminal duct lobular unit, which looks a little bit like this, almost like a bunch of grapes, so to speak. And then the cancer will typically spread along these little duct systems down towards the nipple. Now, epithelial cells line each ductule and are surrounded by more widely spaced myoepithelial cells. This is a lot of science for people who aren't sciencey, but it's going to become important once we start to look at the images and we talk about this. And if you look here, this is a normal duct where we have cells outlining that duct. And here's a duct filled with those cells, something that we call ductal carcinoma in situ. And again, this is going to become important when we look at the imaging in a little bit. So, what does an invasive cancer look like? And I showed you an image like this before. Here we have an MLO view, and anybody in this room who's had a mammogram knows that you get two views for each breast, an MLO view and a craniocaudal view, which is this. And this is one of the special views that you get if you're called back from a screening mammogram, and we do a magnification spot compression view. So why get a mammogram? Well, if we are going to find a cancer, and no one likes to find a cancer, we want to find a cancer when it looks like this, when those cancer cells are confined to the duct, and oftentimes they will calcify and maintain and stay within the duct like this. Now, we don't want to find it here once it's grown outside that ductal system. Now, does all ductal carcinoma in situ become an invasive cancer? No. But this is a very early stage breast cancer. And, okay, so we'll go on from here. The American Cancer Society estimates the number of cases in the United States of ductal carcinoma in situ accounts for almost 25% of all breast cancers diagnosed. Calcifications predictive of ductal carcinoma in situ, which I'll call DCIS going forward, are visible on up to 90% of DCIS cases diagnosed on mammography alone and usually exhibit a clustered, linear, or segmental distribution. Now, do we overtreat? And lots of people, if you read the literature out there and listen to the news, we are accused of overtreating. Well, the natural history of ductal carcinoma in situ and breast cancer overall is poorly understood. 25 to 50% of the smaller lesions recur as invasive disease within 10 to 15 years. At this time, we have no way of knowing which of those will progress. So we should continue to treat them all when detected. So as I was saying, if every woman in this room had a bomb in their kitchen, would you remove the bomb? Of course you would, because we don't know when it's going to go off. So that's why it's important to get your mammogram. Figure out perhaps if you have that early stage breast cancer and have it treated so it doesn't go on to an invasive cancer. However, 80% of the biopsies were performed in breast imaging under mammographic guidance for calcifications or under sonographic guidance for masses are benign. And our imaging tools are sensitive but not very specific. So for all of you who work with women who are getting imaging, whether you work with a surgeon or in a primary care office or you're a nurse, and your patient comes to you upset because the radiologist has recommended they have a biopsy, 80% of the time those biopsies end up being benign. So again, it's a sensitive test. We see lots of things, but a radiologist can't really tell exactly what it is, and that's why we need to get the biopsy for the patient. So, grave misconception. If I have dense breast tissue, a mammogram is not important, which leads us to a discussion about breast density, and this is a very hot topic in a lot of the literature, common literature, and in the medical literature. So we're going to talk a little bit about the normal views that we each get, and here's the craniocaudal view here, where the breast is compressed from top to bottom, and the mediolateral oblique, where the breast is compressed from side to side. And we're going to look in a little bit in the next few slides about the percentage of fibroglandular and fatty tissue. This is the pectoralis muscle. These are some axillary lymph nodes. The fatty component of the breast is dark on a mammogram, and the fibroglandular component is the white part on a mammogram. So the breast density is a way to describe the types of tissue that make up the breast. The breast is made up of glandular or ductal tissue, fibrous connective tissue, and fatty tissue. And the amount of these tissues varies in women. Women who have more fibrous connective and glandular tissue than fatty tissue have more breast density, and that's what we mean by breast density. Breast density can make breast cancer difficult for a radiologist to see on a mammogram. So we divide the breast density into 4 groups, and it's a gross kind of way of looking at the breast tissue, but this would be considered, and any radiologist who looked at this would consider this a fatty breast, which means that the fibroglandular, which as I explained is the white part, makes up about 0 to 25% of the breast tissue. Then we have our standard terminology is scattered fibroglandular density. In this case, 25 to 50% of the breast is composed of the fibroglandular component, the white component. Heterogeneously dense tissue, in this case, 50 to 75% of the breast is composed of the fibroglandular tissue, the white. And then we have extremely dense, which is 75 to 100% of the tissue is made of fibroglandular tissue. Okay, so why is this important? Well, it's twofold. First, mammographic density impacts the detection of breast cancer. Breast cancer sensitivity is markedly lower in women with very dense tissues than in fatty tissues due to the masking. And in a study that looked at more than 300,000 mammograms, the sensitivity of mammography in women with extremely dense tissue was about 62% versus about 88% with women in women who had fatty breast tissue. And we're going to talk a little bit about this in a second. And the second component here is that mammographic density is an independent risk factor for breast cancer. While there are limitations of breast density measures, multiple studies demonstrate that breast cancer risk is increased for women with dense breasts. And in an analysis, and this is an important point here, done looking at breast density, many of the studies looked at very fatty breasts versus the very dense breast tissue. And they detected a 4, almost 5% increase. Well, 80% of women have breast densities in the middle range, where we would call it scattered fibroglandular densities from 20 to 50%, or heterogeneously dense tissue, 50 to 75%. And only about 10% of women have densities within that first range, that very fatty or the extremely dense tissue, at least in our population of patients in the US. In different cultures, those percentages are a little bit different. And when you look at these medium areas, the category 2 and the category 3, that increase in breast density risk is a little bit lower, about 1 to 2 times as much. So again, there's a lot of literature out there. If you go on the internet, they'll say breast density increases your risk of breast cancer. Yes, it does. But then you have to really look at the medical literature and understand what that means, what's being compared to what. And yes, there is some increased risk, but lots of the literature out there suggests that's more significant than perhaps it really is. So breast density is not fixed but may change over time. And paradoxically, breast density tends to gradually decrease with age, although overall risk increases with age. So there's some good things about getting older. Our breast density decreases, but the not so good thing is that our risk increases. All right, so decreasing density over time. Well, what does this mean? Here is just a group of mammograms, 3 between the years of 2000 and 2010. And when you look at these films, you can see that the white, again, the fibroglandular component, is decreasing with time. And we can see that. Oftentimes it's difficult to detect over a 1-year period, but when you look at mammograms over a 10-year period, you can say, hey, yeah, this woman's breast density is really decreasing with time. We can see an overall shift in some women who take the hormonal replacement therapy. You can actually see that increase in the breast parenchyma in the white fibroglandular tissue. So sensitivity of a mammogram. Here we have a category 1, very fatty breast. And the finding here is obvious to anyone. My 5th grader could point this out. Here is a dense breast tissue, and it's a lot harder to detect where that breast cancer is, okay? And now we're going to go to that next slide. Here's the breast cancer here, and if you look on, much easier to see on the CC view, it's right here. So again, much harder to detect a breast cancer, and it takes time For a radiologist, that's why it's often we need to look closely in different ways. A digital mammogram helps very much. Just like you have a digital camera, you can fix those pictures, change them, window them. And so having a digital mammogram helps us detect these cancers a lot better than we were able to in the past. Now, some would argue that having dense breast tissue puts a woman at higher risk of not having her breast cancer detected. And so this is also a hot topic in the literature right now and on many of the news shows, and that is breast density notification to women. 3 years ago, there was a woman in Connecticut who had a late-stage breast cancer missed by her mammogram, and she successfully pushed legislation in her home state for breast density notification to all patients. There's legislation now in the state of New York. Virginia is probably going to be the third state that passes this legislation. Texas and Connecticut have passed it. And essentially what I'm saying to you is that when we, for instance, as a radiologist, when I send a note to Dr. Schnabel about one of her patients, in every report that I send her, I will have one of these lines in here, that this patient has fatty replaced tissue, or scattered fibroglandular densities, or heterogeneously dense tissue, or extremely dense tissue. This information is not sent to the patient at this point. There's no law that we need to send it. However, what these bills are saying is, yes, now we have to alert each patient, each woman that has a mammogram, what her breast density is. And this legislation will probably pass in New York. I'm not sure when, but I suspect probably in the next year. So if I have dense breast tissue, what do I do? Is a mammogram worthwhile at all? Do I need a mammogram and additional imaging? One concern is that women who are told perhaps inaccurately that they have dense tissue will stop having a yearly mammogram. Some are concerned that women will choose to have an MRI or an ultrasound because they are under the false assumption that a mammogram is not worthwhile if they have dense breast tissue. This is wrong. Okay, so if you have dense breast tissue, should you still have a mammogram? Again, someone might come and say to you, well, I have dense breast tissue. I don't need a mammogram. The radiologist can't see anything. We talked a little bit about DCIS before, ductal carcinoma in situ. And I'm sure all of you can see these what we call microcalcifications here. This is extensive ductal carcinoma in situ. This woman has so much disease in her breast that she would probably go on to have a mastectomy because it covers such a large area. This is not something that we're going to see on an ultrasound, nor are we going to see on an MRI. So despite the fact that this woman has dense breast tissue, the mammogram can still give us extremely important information. We can still save lives with a mammogram, even with a woman who has dense breast tissue. Okay, and here's another, and I don't expect you to see these calcifications, but they can also be in a very small area. Here's a very small focus of ductal carcinoma in situ. And again, if I have to find a cancer, this is how I want to find it. A radiologist will go on to biopsy this, and then when it comes back to ductal carcinoma in situ, we'll have her go on and see Dr. Schnabel and have a lumpectomy. So we're finding her cancer at a very early stage. Again, extremely dense breast tissue, but we can still get important information from the study. And just another example of a very small focus of calcifications, again, a focus of ductal carcinoma in situ. She went on to have a lumpectomy and did absolutely fine. So, is a mammogram worthwhile at all? Absolutely yes. Do I need a mammogram and additional imaging? So that's the next question to answer. Freya, I need to ask you, how much time? We're at 7 o'clock. How many more speakers do we have?
One speaker and have till about 7:05.
I have till 7:05? Ooh. All right. Oh, I can't talk that fast. Although don't ask my kids that. They might say I can. All right. So you know what? Let's get to the heart of the matter here. The other imaging tools that we have are ultrasound and MRI. And ultrasound also can give us good information. But essentially the bottom line is defining and figuring out what our risk is, what your risk is as for breast cancer. And when we look at breast ultrasound, whole breast ultrasound, screening ultrasound, and compare it to MRI, hands down, the MRI is the better screening tool to use if a woman needs additional screening, if she's high risk. So let me just skip to I'm not sure if anyone's going to talk about this, but figuring out what your risk is, because this is also another question. Well, how do I know if I'm high risk? If I don't have a sister who has breast cancer and I don't have a mom who has breast cancer and people are talking about high risk, well, how do I figure out? You can go on the internet when you get home, and in less than 5 minutes, you can figure out your risk. And one of the ways to do that, the National Cancer Institute has a website, and there's a breast cancer risk assessment tool that's very simple. Looks just like this, 7 questions that you can answer yes and no answers, and then it will calculate for you what your risk is. So I put in all my information, and so for me right now, I have a 1.5% risk, and an average woman my age has a 1.3% risk, and then it will also calculate your lifetime risk. And how does this help you? Well, if this number is greater than 25%, you are eligible for additional screening. Insurance should pay for you to have additional screening. Now, whether that's an ultrasound or an MRI, that's also to be determined, and financial considerations are there. But if you determine that you're in that risk group of 25%, you can then go to your primary care doctor or your breast surgeon, who can then become an advocate for you, who calls insurance and says, look, this woman has a 25% risk of breast cancer. She needs to have additional imaging. She needs to have an MRI. So again, sometimes we have to take care of ourselves this way and be our own doctors, so to speak, but this is the easy way to do it. So you can figure out, again, what your risk is very easily. Just a recent paper in the Journal of the American Medical Association, April of this year, again, looking at a very important study where MRI was much more effective than ultrasound in detecting cancers in a high-risk group of women. So I just want to show you a few, because it's now 7:06, but I think it's important just to show you what an MRI can do for us. And here's a woman with heterogeneously dense tissue. Very hard for any radiologist to figure out if there's a breast cancer here. Here's, we give each woman contrast when we do an MRI. So here's what we call the typical contrast enhanced, and then a subtracted image. And here, that normal tissue is subtracted completely out. We can't see any evidence of enhancement. Different from this picture. Again, heterogeneously dense breast tissue. The woman gets contrast. We do a subtracted image where we subtract out that normal tissue, and she's got 2 foci here of enhancement, very bright. These ended up being 2 small focuses of cancer. So the MR can give us very good information that no one can find on physical exam, that you can't find on a mammogram, and most people probably couldn't find on an ultrasound. So this, I really need to stop. But I guess the most important thing is this. My request to you, go with a friend who's scared to have a mammogram. Encourage someone who has never had a mammogram to go with you, and take your mother or daughter with you when you go. Thank you.